Six million people are on antiretroviral therapy in sub-Saharan Africa, and the vast majority of those people are receiving that therapy in public health approach settings. In other words, using standardized first-line and second-line therapies, and with CD4 and clinical monitoring without viral load or resistance testing. Now, in terms of the second-line standardized therapy, the WHO recommendation is of a boosted PI plus 2 nucleosides, but there's a big question around what those nucleosides add because of the potential compromise by cross-resistance from first-line therapy. So Ernest had 2 hypotheses. Firstly, that if you replace the nucleosides by raltegravir, a new integrase inhibitor drug, you may have superior efficacy to the extent that that might outweigh the additional cost and possibly also a benefit in toxicity. The other hypothesis we wanted to test was if you get rid of the nucleosides altogether and just use PI monotherapy, that might actually have equivalent efficacy or non-inferior efficacy and reduce the cost, reduce the complexity, and reduce the side effects of the regimen. So the aim of Ernest was to compare these 3 potential regimens, but critically to do so in a way that was relevant to a public health rollout approach setting. So we randomized, or aimed to randomize 1,200 patients who were failing on first-line therapy to one of these 3 regimens. The nucleosides were selected by the physician. There was no resistance testing selection of nucleosides. And with the monotherapy, we had an innovative 12-week induction period where we gave raltegravir to bring the viral load down rapidly for the first 12 weeks. And then we monitored by CD4 and clinical monitoring, as in the public health approach setting, but also included a mechanism for annual viral load and resistance testing, which was done blinded and monitored by a data monitoring committee. So we conducted the study in 14 sites in 5 sub-Saharan African countries. We actually recruited 1,277 patients over a period of just over a year. In terms of the population, actually the majority of the patients were women. The baseline CD4 count was very low and the viral load was very high, so it was typical of an advanced failure population that you'd see in these public health approach settings. Most people had lopinavir as their PI. About 70–80% of people had tenofovir in the nucleoside arm. And the standout statistic really from this trial is the loss to follow-up and withdrawal rate was 1.3%. So it's really outstanding for a clinical trial of this size and scope in Africa. So the principal finding was that there was no difference between the 3 arms on our primary endpoint. And let me just explain the primary endpoint we chose to be relevant to these public health rollout approach settings. So we had a composite endpoint which we called good HIV disease control, which was a composition of being alive and having no WHO4 events after 96 weeks, having a CD4 count above 250, and having a viral load suppressed below 10,000 copies, or if it was above 10,000 copies, to not have any resistance mutations. So the primary endpoint, as I say, showed no difference between the 3 groups. When we look at the components of the primary endpoint, we found no difference in the frequency of death or WHO4 events. Actually, in the standard of care arm, the nucleoside arm, there was 90% survival after 2 years. When we look at the CD4 count, actually that was lower than we'd anticipated. So around 66% of people had a CD4 count above 250 in the standard of care arm. There was a very slight advantage in the raltegravir arm, which didn't reach significance. Another extra 6% of people who had a CD4 count above 250. And when we looked at the viral load, essentially the raltegravir and the standard of care arm was similar, but we saw a reduction in viral load suppression in the PI monotherapy arm, which was borne out also when we looked at the different thresholds of suppression. And also, well, the point to make there, also when we compared the standard of care and the raltegravir, again, there was no difference on any of the viral load suppression thresholds, even going down to 50 copies a mil. They're essentially identical, but there was a drop-off in the PI monotherapy arm. In terms of resistance, we saw a lot more resistance in the PI monotherapy arm as well, and as soon as the data monitoring committee saw that data, they recommended stopping the monotherapy arm and that patients should switch back to combination therapy, which we did immediately. In terms of adverse events, again, there was no difference between the arms. So showing that the nucleosides don't add toxicity in second-line therapy, but equally that there's no advantage of raltegravir. So our results provide a strong endorsement of the WHO recommendations for second-line therapy being a boosted PI, in this case lopinavir plus 2 nucleosides. And this was done again in public health approach settings, so without viral load testing, without resistance testing, and we found 90% survival, as I say, after 2 years, and 86% viral load suppression below 400 copies a mil, which is very surprising. So we believe that this recommended second-line therapy should be made more available in the public health approach. Raltegravir regimen was not superior, a borderline CD4 advantage, but we've got another year of follow-up to see how that plays out and also do the cost-effectiveness calculations. And finally, the PI monotherapy arm was clearly inferior to standard of care arm with lower viral load suppression and more resistance. So this is unsuitable for a public health approach. And I think the most surprising thing to come out of this study was how much these nucleosides, which up until now we thought are probably going to be quite compromised by first-line therapy failure, how much these nucleosides actually add to a second-line regimen. So that was the big surprise to us. Thank you.